Thank you.
All right, I think we're ready to get officially started and stop with our social chit chat. And so hello, everybody. I'm Ellen Polishuk. I'm academic chief for the Division of Collaborative Care and Wellness and the former director of HEAL. It's a true honor to be the one to introduce this important grand rounds today. As you'll soon learn more about, the HEAL Collaborative provides a critically important integration of mental health, legal, and social services all in one place, specifically for those affected by interpersonal violence and trauma. I'm going to keep my comments brief to ensure that there's ample time for the presenters. But before we get started, I just wanted to take a moment to acknowledge Dr. Kate Cerulli. While Dr. Cerulli is well known as an internationally respected researcher in interpersonal violence, it is her unwavering dedication to our community here in Rochester and the area that led to HEAL and allowing it to be born. Her vision, advocacy, close partnership with many who have lived experience with interpersonal violence and years of tireless effort has made HEAL a reality. Thank you, Kate. She's not here today, but thank you, Kate, for everything you did to make HEAL a reality. And now to turn to HEAL. The true heart of HEAL lies in the incredible people and the collaborative spirit that drives their efforts to support patients, families, and colleagues. Each team member, most of whom you see here, exemplifies a remarkable dedication, skill, and compassion in providing trauma-focused care to people during some of the most challenging experiences people can face. I get to introduce Dr. Kristen Holderle, the director of HEAL, who's going to introduce the rest of our speakers today. Dr. Holderle is Associate Professor of Clinical Psychology and Pediatrics. She's been the Clinical Director of HEAL since January 2022. In addition, she is the Associate Director of the Clinical Psychology Training Program and supervises psychology interns on our inpatient medicine and psychiatry unit. Clinically, she is a pediatric psychologist on Pediatric Consult Liaison Service, where she works closely with various medical teams to support children hospitalized at Golisano Children's Hospital. Please join me in welcoming Dr. Holderle, who will be introducing our other speakers.
All right, thanks, Dr. Polishuk. Welcome, everyone. It's so nice to see so many friendly faces in the audience. I'm excited to be here today and to introduce my teammates and co-collaborators. We have a couple people missing, so I'm going to start by just introducing who's here with me, starting to my right, and then talk a little bit about the folks who aren't here before we get started. So right next to me, I have Chinh Huynh. She's a licensed marriage and family therapist working at HEAL since 2017, so right around when it started. She trained in our department and takes a systemic approach to partnering with her patients to work towards empowerment and safety. She provides trauma-focused therapy and is trained in cognitive processing therapy and EMDR. Her other hats in our department include, her other hats in the department reflect her passions to help foster the next generation of therapists and build a diverse and inclusive culture in the department. As such, she's a supervisor in our marriage and family therapy program and serves as a member of our Department of Psychiatry DICE board. Next to Chinh, I have Madeline Sauer. Maddie began her career working with populations facing challenges with substance use and mental health issues, as well as exposure to trauma, community violence, and domestic violence. She joined us at HEAL in October 2023, so she's just about having her 1-year anniversary with us as one of our trauma therapists. She utilizes a person-centered approach along with other trauma-focused therapeutic techniques to help survivors of IPV refine themselves and recover from trauma. Next to her, I have Dr. Vicky Atzl. She is a clinical psychologist who started as faculty in our department just this past July. She works as a clinician in HEAL and also assists me as the assistant director of HEAL, so I'm very glad to have her here for that. She received her PhD in clinical psychology from the University of Denver in 2022 and completed her postdoc training at Mount Hope Family Center. In addition to her time at HEAL, she also provides clinical care at Mental Health and Gender Wellness Clinic. And then last but not least, at the end, we have Kate Stanford. She joined our HEAL team in 2019 and specializes in trauma-focused therapy, taking a holistic view of the journey to wellness. She began her work in IPV at Alternatives for Battered Women, which is now Willow, when she was a graduate student. She utilizes a variety of trauma-focused therapeutic techniques, which allow her to meet people where they are and help them grow into who they wish to be. Understanding the importance of connection in healing trauma, she created and facilitates a series of trauma therapy groups, which she'll be telling you more about today. So this is our group that's going to present to you today. We unfortunately have two people who aren't with us. Shaylah Dorsey is sick, but I wanted to say a couple of things about her because she was supposed to be here presenting with us. She's been with us at HEAL for nearly 6 years, working at as first an OAR and then a PSR role, where she kind of communicated people who called in to HEAL and scheduling them and managing all of that. And we are just thrilled to announce that she recently accepted a position as a mental health intake coordinator with us. So she's transitioning into a more clinical role, which we'll be talking about a little bit. And in addition, her interest was sparked as a result of her working in HEAL, so that now she's working on her social work degree and CASEC certification. So we are sorry she's not here with us, but she's here with us in spirit. And then Emily Weber is not here with us today. She also is a licensed marriage and family therapist who has worked at HEAL since September 2022. And like Dr. Atzl, in addition to her role at HEAL, she also provides clinical care at mental health and gender wellness. So that is the whole HEAL team. So today, let me see if I worked the clicker. I don't know. Sorry, technical difficulty. That works. Okay. So, all right. So, coincidentally, so when we kind of approached Dr. G. Giovanni actually about doing these rounds, we felt like October's Domestic Violence Awareness Month. We wanted to have the opportunity to kind of tell the department about HEAL and the work that we do. And then just coincidentally as well, today is the 25th annual Health Cares About Domestic Violence Day. So just kind of aligned that we are doing this talk on the same day. There are a lot of things going on nationwide in order to kind of recognize the importance of dealing with domestic and interpersonal violence. For anyone who's interested, that link, which obviously you can't click on, but the website's printed there, has a lot of toolkits and other resources for working with individuals with interpersonal violence in the healthcare setting. So as Dr. Polishuk mentioned, HEAL was established in 2017 as a medical legal partnership between us, URMC, Domestic Violence Center, Willow, which is Willow, Domestic Violence Court, and local legal aid societies. So HEAL started out pretty small. The clinical team was just a therapist, a social worker, and an IPV advocate that was based at Willow but worked here with us. And we've grown quite a bit over the last few years. So in terms of our clinical staff, we currently have 2 full-time therapists, 2 part-time therapists, psychologists who does clinical work, and the new mental health intake coordinator position that I mentioned before. So as you can see over time, you know, the needs have grown, and we serve quite a few patients in our community who are dealing with interpersonal violence. We've had a lot of changes over the years in terms of staffing and other things, which we'll talk about a little bit more, but the need is very high, as you'll see in a few slides. So for today, what we really want to do for you guys is to talk about IPV and its impact, and then review the 4 components of HEAL. So I failed to mention at the beginning, but you'll hear a lot about it, that HEAL stands for health, education, advocacy, and legal. So we're going to talk about all of those aspects and what HEAL provides. So what is interpersonal violence? Any behavior within a relationship that causes physical, psychological, or sexual harm in those relationships. And IPV impacts people in lots of ways, both at the individual level in terms of their mental and physical health, as well as family systems and generational impacts, economic impacts. So this is something that impacts people throughout systems and across the lifespan. As I mentioned before, October is Domestic Violence Awareness Month. So we have some statistics here, just kind of general and specific to Monroe County. So about 2 out of 5 women and 1 out of 4 men experience IPV during their lifetime. Also, just to be more inclusive, in terms of people who are transgender, they're 1.7 times more likely than people who are cisgender to experience interpersonal violence. And Monroe County, if you don't know, has the highest rates of domestic violence IPV outside of New York City. So you can see some of the statistics up there from Willow in terms of, and I'm sure some of you who have been around for a while are aware, of some of the more recent events in the news in terms of domestic violence homicides in the area. All right, now I'm going to pass on and kind of have a seat while the rest of you guys take over.
All right, so I'm Maddie, and here at HEAL, our focus is on empowering individuals towards safety, stability, and health through services that are accessible and inclusive. We do this through direct care, as well as consulting throughout the larger system. All right, thank you. So we meet our patients where they're at through a population health, biopsychosocial, and person-centered approach. We also closely collaborate with our other providers as well as our community partners and resources to provide care. So the first pillar of HEAL is health. So and as part of us meeting, I forgot you put that in there. So as part of us trying to meet patients where they're at, everyone attends a needs assessment with us so that we can gather a bit of history to determine which resources they might benefit from, any educational materials they might be interested in, and if they are interested in our trauma-focused therapy, we assess if they're appropriate or if they could benefit from additional services before they start with us, as trauma-focused therapy can be difficult and triggering work.
I'm Kate. Therapy at HEAL is short-term, typically 6 to 12 months, focused on how trauma is impacting people's daily lives. We use a variety of interventions to help patients to recover from the trauma that they've experienced, as well as any intergenerational trauma that they've experienced. Know that, like Maddie mentioned, trauma-focused therapy is very intense and not for everybody. People who are ready to do trauma work, we need to make sure that they have a number of things in place. They need to have good distress tolerance skills. They need to be interested and ready to address trauma. Not everyone is at that point in their life. Some people just need coping strategies to manage symptoms and aren't ready to go through and explore the impact of their trauma in daily life. For safety, we need to make sure that there's no active... So for safety, we need to make sure that people are not engaged in any substance use for 3 months, not at any immediate risk for suicide or homicide, and have good coping skills and support network to prevent any relapses during the trauma therapy work. I run a series of trauma groups. The first group that is offered is a beginning trauma group focused on understanding symptoms and developing coping strategies to manage them more effectively. This is an open group, which means anyone can join at any time. It is gender inclusive. For people who have completed that group, there is 2 other groups that are women-only groups. They are closed groups focused first on reconnecting with feelings. Most of our patients come from a state of numbness. They don't feel safe feeling their feelings. So in this group, we begin to explore what feelings are and how to notice the sensations that they have when they're expressing a feeling. We also talk about shame and guilt and begin to process what life would look like after the traumas and post-traumatic growth. Once they complete that group, they go right into an interpersonal skills group, which again is a closed women's only group, focused on building healthy relationships and learning interpersonal skills, which may not have been developed during their trauma.
Thank you, Kate. This is Vicky Atzl speaking. So I'm going to be speaking about the remaining pillars of HEAL service provision, the next being education. So we really value educating members of the hospital as well as trainees on what intimate partner violence is and appropriate and safe and sensitive ways to manage disclosures from patients about experiences of intimate partner violence. And so to that end, we offer trainings to different departments in the hospital. We've spoken to CPEP and nursing staffs in different departments, among other places, to give them some tools to better understand what signs or signals might be that someone's experiencing IPV, and also how best to manage those situations in a caring way to help maintain patient safety and dignity. We also really value educating the next generation of healthcare providers, and so offer clinical rotations and shadowing opportunities for medical students and residents and master's level trainees in the HEAL clinic, as well as providing a lecture on IPV in the Foundations of Biopsychosocial Practice seminar, and serving as a rotation site for community health and improvement courses. And so this graphic on the side here is a lovely one-pager that was created by a medical student who rotated with us recently about do's and don'ts for appropriate documentation of an IPV disclosure from a patient. Additionally, we also offer a monthly support meeting for any providers who are interfacing with a patient who has disclosed or is experiencing intimate partner violence. This QR code leads you to the registration link, and the link is also there on the slide. We meet the fourth Tuesday of every month from 2 to 3 p.m. And this is more of a drop-in meeting. You don't have to commit to coming every month. You don't have to stay the whole time. But if you have a question or a support need related to supporting a patient who's experiencing intimate partner violence, we're here to answer those questions and provide that support. I'll now talk a bit about advocacy. And all of these pillars to HEAL's mission are really interconnected and integrated with one another. And so our advocacy efforts really dovetail with our educational efforts. And we really see the advocacy work that we do as existing at multiple levels. The first being the individual therapeutic work we do with patients to support their self-efficacy and symptom management to be able to advocate for themselves in a variety of contexts, as well as then connecting patients with advocacy resources and support resources, including Willow Mobile Advocates and Willow's Court Accompaniment Program, as well as Deaf Ignite, which is a program that's also under the Willow umbrella that serves deaf and hard of hearing individuals who've experienced intimate partner violence. And then lastly, and most broadly, we actively are engaged with different community organizations to provide education and support, as well as having an ongoing partnership with Willow Domestic Violence Center, so that at a broad level, we can be thinking on a community level scale how to best support individuals who've experienced intimate partner violence so that they can access all the different levels of support that they might need. And then our final pillar of service provision being legal services. So we have a partnership with 2 local legal aid agencies, Just Cause and Legal Aid, and they host co-located clinics once per month where we have slots for our HEAL patients to then be able to have access for legal consultation. And this can be about a variety of things, including orders of protection, child custody hearings, child support hearings, and other kinds of law enforcement or safety-related legal needs related to experiencing intimate partner violence. And then we also provide assessment to understand who might be eligible for different legal services and legal consultation for IPV-related issues so that we can connect people to the services that they might need, that they might not even know exist or are available for them to navigate such a difficult situation. And now I'll pass it over to Chinh.
Thanks, Vicky. This is Chinh speaking. So I will just talk through ways that patients can get connected to the HEAL clinic and use a case example to kind of illustrate some of these. But essentially, outlined on the slide is kind of 4 examples of ways that patients can connect with the clinic, and those can be kind of independent points of contact, but they can also flow from one to the other. So for example, an example of a first point of contact could be that a patient presents to the emergency room or to the PCP's office and reports an altercation or screens positive for the DV screen. At which point the provider or maybe the social worker would reach out to HEAL and ask for us to come talk to the patient, maybe provide some resources. And a lot of times the patient could potentially decline, and that would be okay. That's pretty common actually, and our goal again is to increase the education, so whether they might need that service in the future, they're aware about it, or again, as we spoke earlier in the presentation, given how prominent IPV is in our community, right, maybe they know somebody else who might benefit from the resource, and so again, they're a little bit more informed. And so then that could flow into a second point of contact, or again, this could be an independent point of contact where a patient shows up and following maybe another altercation or in more distress and is seeking services this time. And so they might get connected to HEAL, do a needs assessment as Maddie detailed, and get options to services, get connected to legal aid, connect with the court advocacy program at Court Downtown to get an order of protection, and maybe get referrals for mental health to start building those distress tolerance skills that Kate was talking about. And then maybe they would then come back for a first episode of care with us. And so they might come back in with the interest to do trauma-focused therapy, as Kate described, but in a place where they are feeling more stable and ready to engage in that level of trauma work. And then in the case example that I will outline as well, another episode of care might be, right, family therapy or couples therapy in the future, where some of their symptoms of trauma are affecting their relationships around them. So I'm going to use this case example to kind of illustrate how those points of contact can occur. So this is a patient who is a 40-year-old female, was married 11 years, and so she initially got referred by her PCP and connected with HEAL. And at that point, she was seeking an order of protection and got connected to legal aid to start exploring divorce options. And so she worked with a member of our team to identify kind of what were some of the steps that she would need to kind of take on those things and identify financial barriers. And there was a lot of ways in which Willow and the team worked together to kind of come up with a plan and help her with so many of these pieces that were quite overwhelming. And so she was able to connect with some social supports who kind of came together, and I think they planned a day to gather at her place to move out all her belongings. She moved in with her mother with the help of her friends while her husband was away. And so she reconnected with me to do an episode of care for individual therapy. She chose to do cognitive processing therapy with me to identify and challenge the negative trauma beliefs that had arose from the relationship. And so as a result, we were able to help her rebuild that sense of safety and trust and intimacy with herself, recognizing her own worth and feeling empowered to express herself. And then about a year later, after her first completed episode of care, she actually reached out and tried to reconnect because she was having some conflict with her mother that she had moved in with at the time. So again, she was 4 years old, her mom was maybe around 65, and there was a lot of interactions at home that were bringing up this sense of disempowerment that were reminding her of her trauma. And so some of the work, the mother agreed to engage in family therapy with me. And some of the work that we did was working on kind of building a sense of empathy for each of their experiences and educating the mom a little bit on how patients' trauma symptoms, right, weren't necessarily about her, but how they could be echoed in the relationship, and helping improve their relationship and understand each other's perspective. I'm going to pass it on to Kate for another case example.
This is Kate speaking. I'm going to talk you through a case that I worked with for a individual who had 2 episodes of care with me. So she is a 44-year-old female with 4 adult children. Our first episode of care was from September of 22 to January of 23. She has a complex trauma history beginning in early childhood and continuing into her marriage. At the age of 3, she began being molested and sexually abused. At the age of 11, she was raped by 2 men and began to disassociate after that time. She reports promiscuity with adult males beginning in her teenage years, described emotional abuse and neglect by her mother, who was clinically depressed throughout her childhood, and reports physical and financial as well as emotional abuse by her ex-husband. Patient had a history of depression throughout her lifetime. There was no suicidal ideation or self-injurious behavior, aside from a time when there was an interaction with medication which caused her to feel suicidal. Once the medication was stopped, there was no suicidal ideation. She had significant anxiety symptoms at the start of our first episode of care, as well as depression. At that time, she did not meet criteria for PTSD. There was no history of substance use or substance treatment. Her working diagnosis was a mild episode of recurrent major depressive disorder and generalized anxiety disorder. She had a history of treatment for mental health issues that goes back about 20 years, and she had worked with Genesee Mental Health Center and Willow and was beginning treatment at Strong Behavioral Outpatient before the pandemic started. She has a good supportive relationship with her adult children. She was raised in Rochester along with 4 siblings. Her father was not present during her childhood, and her mother struggled with clinical depression, leading to emotional abuse and neglect throughout her upbringing. Both of her parents had passed away at this time. There's also a family history of clinical depression. Her maternal grandmother was also diagnosed. At the time of the first episode of care, there was an order of protection against her ex-husband, which would be running out within a few weeks of our starting treatment together. Her focus was on processing the traumas and learning coping strategies to manage the symptoms. By the end of the episode of care, she was utilizing skills on a daily basis and reported significant decrease in symptoms. She was able to explore and process some of the traumas throughout her lifetime. She was able to set healthy boundaries and develop relationships that were supportive and positive for her. And at the end, she indicated she had met goals and described feeling at peace and content. Fast forward about a year and a half later, in April of 2024, she came back for a second episode of care. In January of that year, she was sexually assaulted by an ex-boyfriend when she refused to have sex with him. She's currently taking him to court, and there were charges pending. Her focus of this episode was to be able to speak in court about what happened in front of her assailant and be able to do that without being overwhelmed. So we worked together to develop ways for her to manage the symptoms while sitting in court so that she would be able to speak clearly about what happened. She went into court knowing that she was not going to win. Regardless of the evidence, she was going to lose. And yet she still had the courage to go in and speak her truth about what happened. The case was dismissed. She also struggled throughout the episode of care with feeling safe leaving her home because there were a number of acquaintances of this assailant who would stalk her. So she had cameras in her home. She was leery about leaving, so she had to leave her job. She stopped going to school because she was at Finger Lakes Community College. And by the end of the episode of care, after speaking in court, she was able to feel safe leaving her home. She returned to school and had started a new job. When she ended this episode of care, she noted she had developed a sense of self-respect and self-love and felt safe with her new job and was working with her children to break an intergenerational trauma pattern. One of the things about this case is that for her, the outcome was what she expected, and yet she was able to heal herself from what she had experienced despite not having support through the court system. Unfortunately, that is not unusual for our IPV victims. Often they find themselves on the losing end of court cases. I'm going to turn it over to Kristen.
All right, thanks. I'm back. So on this slide, maybe about a year ago or so, we did a QI project just to assess how patients were, receiving the care at HEAL and kind of getting feedback from them. So this is some of the feedback that we have gotten from patients. I think, one of the reasons that HEAL was started was to be able to break down some of the silos and barriers that people have when they have to dealing with interpersonal trauma and the legal system and things like that. And so I think some of the feedback we have gotten has been very positive as far as patients feeling that they learned tools that they needed, they were able to grow, and that the program really supported them in lots of different ways. So I just wanted to spend a few minutes talking about what's next, and then hopefully we have left enough time for kind of some questions and discussion. So as I mentioned earlier, we have a new position that we just hired Shaylah, our ESR, to move into. So when HEAL started, we had a partnership with, well, we still do have a partnership with Willow, but Willow had an advocate that was on site and able to go to the emergency rooms and to the floors and things like that to be able to kind of work immediately with patients. And just unfortunately, in the last couple of years, especially since the pandemic hit, it has been so hard to staff that position. So we have, the last couple of years, have only been able to have an advocate on site for like a few months, basically. Like we'll get someone new and then they quit Willow and then we don't have someone for a while. Similarly, we have gone through several social workers. As you can imagine, it is like a very demanding population to work with. So we're lucky to have so many dedicated individuals who have been here for a long time. But so we decided moving forward to make this mental health coordinator position that will function similarly to sort of a advocate and social work kind of role. So be able to pretty immediately meet people's needs when they're in the hospital, which is something that we know from talking to people on the medical floors they really miss. We get a lot of calls about we have someone in the ED or on the floor and they really want like a warm handoff or point of contact and we don't have anyone to send to them. So this new role will allow us to get back to doing that, as well as be able to do really brief screenings with people upon the first point of contact on the phone to help figure out and triage what they need and where we can connect them to, because we have ended up having sort of a bottleneck, which when people call, they have to like wait to meet with someone for a needs assessment and then be connected to services. And so this will hopefully help to get things moving a lot faster in terms of meeting patients' needs. So we're very excited about this. Stay tuned. Shaylah has officially started in this new role as of this week, but because we are not wanting to leave all of our support staff in the lurch, she's having a couple of weeks of sort of overlap in her current role, and then probably by the beginning of November, we'll be starting. So for those of you on the inpatient units, like if you need assistance, you can call HEAL and we will have someone available to come help more quickly. The other couple things that we are focused on too, with the hiring of Dr. Atzl, there will be more person power to help with some QI projects, hopefully. And also getting back to when Dr. Polishek started HEAL, it was initially under a research grant. There was a lot of data being collected from patients. That has also sort of reduced over time with the pandemic and people not coming into the office as much and not, being here to fill things out. But we're really wanting to work on figuring out what our standardized, consistent measurements are and making sure people are following through on completing them. We have a lot of data that we can look at too. So those are some things we're focused on, as well as expanding our educational opportunities. So I know I have talked to Dr. Eiler and Dr. Nazra about being able to supervise psychiatry residents who are interested in rotating through HEAL. So I know some of you have spoken with me about that as well. Just for those of you who are interested in referring to HEAL, there is a e-record referral. This is the best way to refer to us. Patients can also self-refer by calling 275-HEAL. For those of you who are in different clinical areas and want some brochures from HEAL, or even brochures about Willow and other things about IPV, you can email us or call, and we will get those to you. Also, if you have questions, if you're working with patients and you're not sure and you want to have those questions answered, the support group that meets once a month is a good opportunity to get one of the HEAL clinicians like live in person to kind of talk through things. You can also call us and we can do consults with you. We also, as Vicky mentioned, do a lot of education throughout the entire hospital. So if you want more information about working with individuals with IPV, we can come talk to your group and help you work out any particular issues that you're wanting to deal with regarding IPV or charting about IPV or legal questions or those sorts of things. We have lots of people we want to thank. So this is our acknowledgement slide, especially Dr. Polishuk, Dr. Cerulli, Dr. Morse, all of who are have been very instrumental in kind of getting things started and supporting us. And I think that's it. So we have hopefully lots of time for any questions, comments, feedback.
Thank you, everybody, for a great presentation that I think both shows how important it is to be thinking about IPV and the important work that HEAL is doing and the great teamwork. I just want to comment on what a humble group this is. I don't know if you can hear how much they really bring to the table and how powerful the work that they do is. So thank you very much. First, I'd like to see if there are people in the room who have comments or questions they'd like to ask or raise.
Good afternoon, everybody. Wow, that's really loud. Thank you for that discussion. My question, earlier in your slides, you pointed out that it's beneficial or expected that someone is free from substance use for 3 months, maybe specifically for some of the cognitive process therapy that you were talking about. Do you have a sense of, and obviously there's connections like our other SUD-related services if someone struggles with that. Do you have a sense of the volume of patients that have some sort of SUD challenge that are sort of co-presenting with that and how that navigation has gone? Just based on my SUD work, I'm thinking about how many patients might turn to that as sort of an intermediary coping skill, and do we have data to demonstrate how we're able to sort of co-manage those things, or how we work with our SUD clinical areas to try to help somebody on that first step?
Yeah, I can say a little bit, and then I'm happy to have you guys add if you want anything. I don't have any data per se. I think it's very highly comorbid in a lot of ways, and one of the reasons for the stability piece is just that when you start to really do trauma work, if someone doesn't have any coping skills other than substance use, then we could potentially cause more harm. And so I'll let the clinicians speak more to their experience, but there is definitely room for and opportunity to do co-management. And it's not an absolute rule out, right? So we try to think about things in terms of context. And if people are being supported in substance use treatment, it could make sense to do treatment at HEAL at the same time, as long as that's being addressed. We just don't want to miss it and then cause a problem to be worse. But I don't know if you guys want to add anything.
So I actually spent 7 years as a drug and alcohol counselor. So I'm also now helping bring kind of that knowledge base to the team. So I also help consult if they end up with somebody, especially nowadays, marijuana is a big user one and it's legal. So everyone's like, we can use it, So it's like assessing, are you using like 9 blunts a day, or is it, because that's quite an extensive amount. Are you using it as a coping skill? Or is it more like you're just using it, or is it medical marijuana? It's like once or twice a week, once or twice a day. So we kind of work around it as well. Sometimes we do encourage folks to do a substance use evaluation. And then if they are recommended treatment, we do encourage them to follow through with that. Anyone else have anything?
I think, yeah, just to reiterate that criteria is really for the trauma-focused work, right? And so part of that discussion is kind of educating on the patient on like what trauma-focused work could look like and why we're recommending this in terms of, for our team, it's really important that this is done safely, right? We have seen in so many of our patient population how trauma work can be re-traumatizing for so many patients. And it's so important for us that this feels like a safe and collaborative process. And so understanding what that could look like and what are the things that contribute to the success, and seeing if we can come up with a collaborative plan of like what that could look like if it's now, or if it's in 6 months, right? Just to try to see that we're really setting the patient up for a success as we best understand it.
It's not uncommon to kind of have people wait on our waiting list, right? Like they do the needs assessment and we say like, we think some more support with substance use therapy is worthwhile, and we'll loop back with you in 3 months and like see where things stand. So we don't like close the door and say no, so. I think you had a question.
She scooped me. I had the same question.
Okay. Well, glad we could answer it preemptively.
Yeah, women with substance use disorders tend to have partners with substance use disorders, and violence is quite common in that scenario. So it is a high need population, and I do think sort of some of the flexibility you're describing is really appreciated, and moving toward integrating substance use work with HEAL, it would be a great direction.
Great, thank you.
We have a few questions in the Q&A too. Can a patient come work with you on trauma and keep their primary therapist within the institution to continue work on other goals or mental health needs?
So For us to do trauma work effectively, we need to be the primary therapist. What we want to do is make sure that there's no triangulation between therapists. So when somebody comes to heal, they are only working with us. Remembering that our episode of care is only 6 months to a year in length, and in which time they could go back to their primary therapist at that point.
What about group?
With group therapy, they stay with their primary therapist and would just see me for group while working with their individual therapist.
Thank you.
And I think, again, there could be opportunities for flexibility. There's likely insurance reasons sometimes that people couldn't see two therapists at the same time. But like if someone was in couples therapy, maybe, for example, separately and also seeing heal. So our therapists work very closely with primary therapists who refer, and often we'll do consultation with the therapist who wants to refer to heal to kind of talk about how are we going to work together around our episodes of care. So
Yeah, we've had patients who are like worried about losing their existing therapist, and we've had transfers kind of happen where we come up with an agreement where they will come work with us for a certain amount of time and transfer back to their individual therapist once they've completed their episode of care with us.
Thank you. Perpetrators of IPV, who often are the respondents of order of protection, have a high rate of suicide. Are there services for them as well as victims?
that's a really good question. I mean, we do not have services for them at HEAL currently. I don't know if there's something else.
So historically, if they identify their own trauma history that they are seeking to address themselves, they could come see us for services. In terms of community resources for perpetrators, I think it's limited. I can think of maybe 1 or 2 clinics.
Yeah, I was gonna say Endeavor comes to mind. That's, I think, where most people are referred to if they are a perpetrator themselves, because it's often court ordered, and I know that they work quite frequently with them.
Thank you.
Sounds like that's an area
Yeah,
for someone to explore more.
definitely a need. What supports are there for children who have witnessed IPV?
While our clinic focuses on mental health and other coordinated supports for adults, I'll just give a shout out to the Mount Hope Family Center, which is part of the URMC family and where I did my postdoctoral training. And they have supports for children and families who've experienced interpersonal violence, both through DSS and CPS, but also through community referrals. So that would be a really nice place to refer families to if they're concerned. In addition, the National Child Traumatic Stress Network, or NCTSN, has a wonderful website with a lot of helpful one-pagers and guides to provide information and education, and also ideas for how to explain intimate partner violence at a developmentally appropriate level to a child. So that could be a resource to direct a parent to.
Thank you, Dr. Atzl. Can an adult patient who may be experiencing emotional abuse, physical, financial abuse from a family member, for example, a parent or sibling, be referred to HEAL?
Yes, anyone with a history of interpersonal violence, doesn't matter what the context of the relationship is.
And how do you define interpersonal violence?
Oh,
Like, what are the parameters around that?
I'll let you take that one, Chinh.
If there is a relationship, we're pretty open. So I think in the past we've turned down referrals for a medical trauma, a car accident, that kind of thing. But if there is a work relationship, a family relationship, we count that under the interpersonal umbrella, and we will usually accept that referral.
Thank you. Once again, thanks for the flexibility. Go ahead.
And I was just going to add as well that this can be someone who was maybe previously in a relationship and now they're ex-partners, but are still continuing to be abused or stalked. So it doesn't have to be a current relationship if there's current ongoing interpersonal violence occurring.
Does HEAL have a provider for medication management?
We do not currently have a provider for medication management, but we utilize providers within the Collaborative Care and Wellness Division to, do evaluation, consultation, prescribing if needed. So we're able to refer for that.
And you would determine when that's needed, or what does that look like?
I think it's usually patient driven, potentially, like if a patient's interested in medication.
Yeah, I'll just add, I think so our needs assessment process initially really tries to triage. Okay, thank you. Our needs assessment is really designed to try to understand the wide-ranging needs that the patient might have in terms of interest in mental health therapy, legal consultation, other kinds of IPV-related needs, and oftentimes things like health or medication needs come up then too, and so then we can refer to the appropriate providers for that. Other times during the course of therapy, as we get to know our individual clients and their needs, or are monitoring whether or not they're making progress with therapy alone, then we're able to talk to them about whether or not psychiatric medication would be helpful, and then make that referral to the provider for collaborative care and wellness.
So yeah, usually if patient express an interest, I think two of the main pathways that I consider is a referral to Elisa Curley within the Division of Collaborative Care and Wellness, who could do med management as long as patient is currently engaged with us as a therapist. But we also utilize the psychiatric consultation service through Department of Psychiatry, which I believe if the PCP agrees to prescribe, then you can do a referral where patient meets with the psychiatrist for 2 appointments and makes a recommendation on medication recommendations for the PCP to follow. And again, I've had patients who have done that service and then were on a medication for maybe 6 months, and then it just wasn't working, so we did the re-referral, and they accepted that as well.
Maddie and I both attend weekly treatment team rounds with Strong Minds, and so some of our patients are connected through Strong Minds prescribers as well, just because of the collaborative relationship with that group.
Do you make referrals for the children of parents that come to your clinic?
Yes, we can provide information about the different resources within the URMC network, as well as if there's somebody in the community, we help connect them.
And I'll just acknowledge that Chinh and Emily are both marriage and family therapists and really bring a family approach when appropriate to supporting families coping with violence. I wonder about how HEAL might support transgender individuals who have experienced IPV. You mentioned that some of your groups were for women only. How does gender identity play into the resources available?
Well, I'll maybe bump it to you to talk about the group specifically, but in terms of our general service provision, anyone of any gender identity is welcome to come to HEAL and receive services at HEAL. And we also know from research that individuals who are transgender or gender nonconforming, or who have a minoritized sexual orientation, can experience IPV at higher rates, and also intimate partner violence that is specific to that identity, where the perpetrator of abuse might threaten or disclose that identity to people the patient doesn't want to know, or use that identity in a coercive or controlling manner. So it is something that we really think carefully about when providing services to individuals who've experienced IPV, and that IPV can occur in any kind of relationship. And if we're talking about a romantic relationship, that can include same-sex couples or couples with all kinds of gender identities. And then Kate, did you want to mention the group?
So the beginning trauma group is open to any gender. That group really focuses on gaining an understanding of trauma symptoms and developing coping strategies to manage it more effectively. Once that group is completed, they're welcome to come do individual trauma-focused therapy with us and really start to address their own individual needs.
Thank you. Are there any more questions in the room before I jump in with some of my own questions? Yeah.
Hi, I was a little late, so sorry if I missed this, but I was just wondering if you could speak more to like barriers that you faced in helping your patients clinically. Yeah.
Wants to take that one?
One thing that I think comes up a lot and why our medical legal partnership model is so essential is that there are a lot of competing needs that our patients face. And so the trauma-focused treatment is really important when people are ready for it, but that's just one kind of piece of the puzzle, and that individuals experiencing intimate partner violence and then subsequent fallout really have varied contextual stressors and needs. And so being able to connect them with legal and advocacy services is essential, and that can also be really challenging because then we're helping our patients manage really big feelings about times where maybe our systems let them down because those systems are really imperfect and also really understaffed and underfunded often, and so we can direct them to those places and have partnerships with those places, and sometimes it can be challenging to connect all of those dots to make sure that people are safe and healthy. So I think that can be one of the biggest challenges, and then those kinds of legal appointments or medical appointments or advocacy appointments can also sometimes make it difficult to engage in therapy in a regular manner too. So I think having the ability to give patients grace for that and also problem solve with them collaboratively about how to manage all of the different things going on is really important to help them stay engaged with therapy in addition to the other services that they're trying to access. Does anyone else have other thoughts?
I was just going to add too that I think, Kate spoke to this in her case presentation as well, but there are so many, and I know Vicky just said also, there's so many systemic issues, especially within like working with the police or the legal system or things. And so a lot of times coming up with how to help patients feel hopeful about things when we know that it's probably not going to go their way when they go to court or other things can be really challenging. And we also hear a lot of stories from patients about the ways that technology is changing so much faster than we can understand it and really has a different landscape on safety for people because they can be tracked or have other things happen that like the legal system can't even keep up with yet in terms of putting orders of protection or things like that. And so we tend to have those sorts of conversations about how to address those with patients or who we can like link them to try to help those with those sorts of issues, which can be really challenging. We've worked with like ISD here in terms of privacy issues. When an Epic update went out, it all of a sudden started showing where the clinic appointment was. Instead of just saying like URMC, Department of Psychiatry, it said like Heal Collaborative, and a patient's abuser saw it in their email that they had an appointment reminder for that and Googled what it was, and it caused a safety issue. And so we had to like then have that remasked within the system so that it didn't cause undue harm to people. So technology is one of our like, I think, biggest barriers in some ways too.
I'll also add to that I had a patient who was a firefighter, and recognizing that if their abuser is a police officer or a firefighter, they are well aware of where the Willow Safe House is because they have to know how to access hard to access buildings. So keeping in mind that they might have to also look for services further out simply because of who the abuser is within the community.
And I think being very conscious about what you're putting in notes is important because those notes have a lot of power. They can be called into court and used against somebody in a divorce. We had one patient who there was an error in one of the notes that said that she was a substance user when her ex actually was. And the children were taken away from her and placed with him. And it took about a year for her to get her children back. So just being very conscious of what we're writing. There's a lot of power in our notes.
I think another piece I love working with this population, and it's a really, really hard population to work with. And the recognition that sometimes, the importance of meeting patients where they're at, right? And that might not be where you want them to be, but to be able to recognize where they're at. And so I think the expectation that patients oftentimes have to reach out several times, and that's normal, right? And so recognizing, I think, your own frustration with that or your own desire to help and how that can interfere with recognizing patients' needs in the moment and meeting them where they're at. I think a lot of our patient population encounter really well-intentioned providers who then make them feel judged or pressured because they're offering all of these solutions and patient doesn't take them, right? But there's so many reasons why patients are not able to take them in that moment. And that is their own journey to take. And we want to be able to help them along with that journey, but it really is theirs. And so I think recognizing what comes up for you as a provider is really, really important and can be some of the barriers.
And just kind of going off of what Chinh was saying, that's part of why we have the IPV group for consultation, is to talk these things through and recognizing that most people leave and return to the relationship 6 to 9 times before they leave for good. So it's a process.
Thank you. And that leads directly to the question I want to ask that I think will be our last question for today, is this is tough work, as you're all articulating. And I think that many of us have had our own experiences working with people experiencing really profound trauma and the repercussions of that. How do you take care of yourselves and keep going as a clinician to keep doing this important work?
So I've been doing this work, not at HEAL, but throughout my career for almost 18 years. And I think for me, the reward is watching when people can break intergenerational trauma patterns and create new lives for themselves and their children. For me, having different hobbies and things that I enjoy doing, my husband and I both joke about wind therapy. We both have motorcycles. So that for us is a big thing that we do, and we do a lot of camping. Just getting away from technology and being able to reconnect.
I know for me, using my teammates as support, and then also I have some friends that are also in the field, so they sometimes are like, they call and they go, man, that was a full moon week, wasn't it? And we go, yes, it was. And then I also, as Vicky pointed out, I brought my turtle to fidget with today. So it's also not only teaching our clients skills, but also using our own skills as well.
And I think as a team too, we make an effort to be supportive of one another and also celebrate each other's achievements. And the beginning of each of our weekly team meetings, Kristen always asks like what's going well and to check in about things to celebrate, whether it be personal or professional, big or small. And so being able to take the time to really let those, savor those things, even if they're small gains with a client or something else professionally or personally that we want to celebrate, I think is really helpful as a team to cope with the work that we're doing.
I think I'm on a kind of never-ending journey of kind of learning about myself. And so building that awareness of myself, of where I'm at every day is really important, right? Not where I want to be, but where I'm actually at, what I'm struggling with, because, right, I'm better able to take care of my patients when I can take care of myself as well. And so I think previously I came from a space of like, I can push through, I can make it, whatever is asked of me, I can take it on. But that really leads to burnout. And so challenging myself to be honest with myself has been really important as part of my self-care.
Thank you very much for a wonderful presentation today. I think we all learned a lot, so thank you. Oh, it didn't?